ऐसे ही रखना, थोड़ी ये भी दीजिए और ये स्क्रीन भी दीजिए, स्क्रीन भी चल रहा है। ठीक है, काम करो नहीं करता। तो ये अब इसको बढ़ाएंगे तो फिर ये स्क्रीन ज़्यादा वाइट हो जाएगी, दिखेगा नहीं ना। हाँ वो तो समझ गया, इसको बढ़ाएंगे तो अब वो आउट हो जाएगा। हाँ इसलिए वो भी दिखाना कि कौन किसकी स्पीड दे रहा है। करो बढ़िया। अब इसमें और कोई सेटिंग वेटिंग हो? कोई सेटिंग नहीं, कुछ नहीं है ना। बढ़िया है, आवाज़ बस आ रही है, चेक कर लेना एक बार, कान में सुन लेना कि आवाज़ आ रही है।
On the behalf of IRA to this talk on osteoporosis. First and foremost, I would like to welcome Dr. Varghese, Dr. Jacob, Dr. Preeti and Dr. Bandita to the stage for the talk. Start with, I would like to invite Dr. Vidita Pinto, consultant at Manipal Hospital, Bengaluru, to start with a talk on osteoporosis. Thank you, Dr. Archana. So I
लाइट कम ज़्यादा सेट करके रखना है स्क्रीन और रिकॉर्डिंग.
So good morning. We have very few people in the hall, but this is a rather interesting scenario, and I'm sure all of us would have at some point of time come across this in clinical practice. The most commonly used tool for the diagnosis of osteoporosis and also endorsed by the WHO is the bone mineral density DEXA, and the WHO defines osteoporosis as a T-score less than -2.5. So osteoporosis, while being the most common cause of a low BMD, is not the only cause of a low BMD. So usually osteoporosis is an asymptomatic disease and is usually diagnosed only on screening, unless and until it presents with a fragility fracture. So when we consider, so the other area which is sort of in which the definitions are not clear is in patients who are in premenopausal women and young adults, in which the definitions of osteoporosis are not clear. Currently what we take is a Z-score less than -2. Z's rather than using the T-score. So the Z-score is what is used in young adults. However, again, it is to be understood that this whole whenever we have a patient in which whom we are suspecting osteoporosis in the young, it is usually we consider secondary osteoporosis. So here I am going to highlight a case in whom there was a diagnostic dilemma because of the presentation, and also go through some of the available literature. This was a 40-year-old male who presented with pain in the back and hip, and this was a long duration of a 6 years duration. And patients started with a low backache, which was insidious onset and slowly progressive, with an early morning stiffness of greater than 1 hour. So while the history sounded very much like an inflammatory backache which occurs in spondyloarthritis, and he initially had some partial response to NSAIDs. Over the next 3 years, there was pain in the chest, and there was also generalized body ache. And he met several physicians over the course of the 6 years, and about 3 years previous to presentation to us, he was diagnosed with ankylosing spondylitis and initiated on sulfasalazine. We did not have records on the basis of a diagnosis, but we could find prescriptions of sulfasalazine. But of course, he had no response to treatment, which could of course be because not everybody responds to sulfasalazine, but instead of pursuing the diagnosis, he started alternative medicines without response. For the last 3 years, he had developed severe pain in bilateral hip. We have to note here that his pain scores were almost 8 to 9 on 10. It was very, very severe pain. At presentation to us, his primary complaint was a left hip pain, which was of 6 months duration. He was evaluated outside, and we had actually seen multiple ESR CRP reports which were negative. However, there was an MRI which was reported as a sacroiliitis, and films were not available. We also had a BMD DEXA done outside, which showed low T-scores and low Z-scores, and thereby he was referred to us as a spondyloarthritis with osteoporosis. And this was the referral from the spine surgeon who had initially seen him. So when we saw him, the first thing of course that we did was was an X-ray of the pelvis. Here the sacroiliac joints looked pretty alright to us, although it's not a very clear sacroiliac joint like we would expect in a young 40-year-old male. Slight blurring of the margins in the left side. However, what was the most important finding was this fracture of the pubic ramus. We also, this was what he was referred to us with these X-rays, and we have this biconcave shaped vertebra. So, we doubted the diagnosis of spondyloarthritis, and we got a few other investigations done, an ESR which was 34, CRP which was absolutely normal, and there were multiple previous reports also which were similar. Liver function test showed an ALP of 258 with a cutoff of 135. Serum calcium was normal, however there was a low phosphorus, and this also we repeated twice, and it was 1.5. PTH was normal, and vitamin D was normal, and HLA-B27 was negative. So, at this point we suspected that because of the hypophosphatemia and the long history and the severe pain and the presence of an insufficiency fracture, that is a pubic ramus fracture, we suspected that this was probably osteomalacia due to hypophosphatemia. So, suspecting a tumor-induced osteomalacia, this was the PET CT. I'm just showing these images because he also had a rib pain, and then when we did the PET CT, the CT images are showing multiple rib fractures with callus formation. These are healing rib fractures. This is the pubic ramus fracture which I already showed on the X-ray, better delineated on a CT cut. And this was the showing of, this was the PET image, and it showed a focally increased somatostatin receptor expression in the inferior alveolar process. So this confirmed our diagnosis of tumor-induced osteomalacia, which was the cause of the patient's pain as well as the low BMD in this patient, which was due to osteomalacia rather than osteoporosis. So coming to the point of discussion here, osteomalacia. Osteomalacia in the initial stages is an asymptomatic disease but can present with bone pain, muscle weakness, fractures and impaired gait. And the DEXA can be extremely variable. There are numerous studies which have been done on DEXA in osteomalacia, and in later stages it is osteomalacia patients tend to show very low BMD scores. Diagnosis is typically based on clinical symptoms, findings on laboratory and radiological studies. However, the bone biopsy is a confirmatory test. In most clinical scenarios, we don't need a tetracycline labeling and a bone biopsy to make a diagnosis of osteomalacia. To consider some of the non-osteoporotic causes of low bone mineral density, so you can, in osteomalacia, the PTH-mediated disorders, FGF23 mediated disorders, like in this patient, tumor-induced osteomalacia is a paraneoplastic condition in which a tumor is producing excess FGF23, which thereby leads to phosphaturia and low hypophosphatemia leading to osteomalacia. And renal mediated disorders. Other conditions include osteogenesis imperfecta and other hereditary connective tissue diseases like Ehlers-Danlos, Marfan syndrome, CKD bone mineral disorder, and other rare diseases like type 1 neurofibromatosis and fibrous dysplasia. So, the mechanisms of osteomalacia we're all aware. The commonest one is nutritional, that we see vitamin D deficiency. It is in recent times pretty rare to see a patient with pure vitamin D deficiency presenting with osteomalacia. Most of these are due to malabsorption and other etiologies. We have renal insufficiency in which decreased 1-alpha hydroxylase and hepatic insufficiency. The FGF23 mediated disorder, tumor-induced osteomalacia among this. Usually there is a mesenchymal tumor which autonomously secretes FGF23, and it is an acquired disorder. I'll come to more details about it. And there are others in this category, which is X-linked hypophosphatemic rickets, which is genetic, which these present usually in childhood. So, what does FGF23 do? FGF23 is secreted by osteocytes, and this is in response to increased phosphate, and FGF23 decreases phosphate reabsorption. So that way it is a phosphaturic, and thereby inappropriate secretion of FGF23 will lead to renal phosphorus wasting and osteomalacia. So this is another case. There are actually quite a few case reports of osteomalacia presenting or being treated as spondyloarthritis. In this, similar to our patient, a 25-year-old man was treated as ankylosing spondylitis and osteoporotic compression fracture before this diagnosis could be made. So this is another paper that I could find in which they had looked at differences. It's about 70 patients, group of 70 patients, 35 with osteomalacia and 35 with spondyloarthritis. And there were at least 13 patients of this in osteomalacia were tumor-induced osteomalacia. So patients with osteomalacia, numerous patients had been misdiagnosed. These patients were misdiagnosed with spondyloarthritis. And because they came with backache, some of them came with peripheral arthralgia, some of them, many of them presented with hip pain because of the pelvic fractures. So looking at the laboratory tests, the most important thing to note is of course the alkaline phosphatase in osteomalacia versus spondyloarthritis. The ESR and CRP, the inflammatory markers, tend to be normal. However, one should note that the bone mineral density is much lower in osteomalacia compared to spondyloarthritis. And this is because usually in ankylosing spondylitis we get new bone formation, and DEXA is not a very good measure of osteoporosis in spondyloarthritis. However, this osteomalacia, they tended to have much lower BMD DEXA scores compared to SPA. The other most interesting part of the paper is they had actually about 10 patients in osteomalacia had undergone an MRI to look at sacroiliitis, and as per the ASAS definition, 75% of them had a positive ASAS definition for sacroiliitis, which is bone marrow edema. So because although erosions were not found, so erosions were not found, however the SI joint was a little bit, on the CT cuts in many patients, the SI joint was irregular. It was not as clean as would be expected. Thereby, many of the patients, the radiology had been misinterpreted as a sacroiliitis. So this was a systematic review of 895 cases of tumor-induced osteomalacia, in which the diagnostic delay was longer than 2 years in more than 80% of the patients. Most of the in tumor-induced osteomalacia, most 90% of the tumors are benign, and that is why these patients, the predominant presentation is only the hypophosphatemia and osteomalacia. That is why there is such a huge diagnostic delay. Most of these tumors tend to be internal, they are small, the lower limbs being the commonest site for these tumors, followed by the head and neck region. And of late, the diagnosis of these tumors and localization has gotten better because of PET CT and somatographin receptor techniques, which enable us to identify this mesenchymal tumors. So this was another, this is from the same review. Again, you can see the BMD scores in this condition. In both, external are the tumors that were found on physical examination, internal are the tumors that were diagnosed only after PET CT. And you can look at the BMDs in both these. And of course, the diagnostic delay here in the external group 4 years, internal group 3 years. So they're quite a significant diagnostic delay before these tumors are picked up. So these are the common symptoms of TIO. Bone pain, difficulty in walking, pathological fracture. All these are usually reported in most patients. So these are the common misdiagnoses, and this was a series of about 450 patients in which they looked at all the, 125 patients, and these are 240 times the different diagnoses were made in these patients, in these subset of patients. And some of the common diagnoses made was intervertebral disc herniation, spondyloarthritis, followed by osteoporosis. So these are the commonest diagnoses that are made while the patients present and get diagnosed with a tumor-induced osteomalacia. So the take-home messages are that osteoporosis is not the only cause of a low BMD, although it is the commonest cause of a low BMD, and clinical features offer very important clue. It is very important to remember that osteoporosis does not cause pain unless it is accompanied by a fracture. Osteomalacia, on the other hand, is a disease which is commonly accompanied by pain, and before starting treatment, especially very, very important before starting treatment, to order a calcium profile, which is easily available everywhere. This does not usually include a PTH, and most endocrine societies don't always recommend a PTH. They recommend just calcium, phosphorus and ALP, which is very, very easily available, and which will enable us to diagnose most bone disorders, metabolic bone disorders. In this situation, for example, we had a low phosphorus which led to the diagnosis of osteomalacia. So it is very important to get these basic tests done because what you're using for treatment of osteoporosis are usually antiresorptives which can lead to very, very severe hypocalcemia in the presence of osteomalacia or a vitamin D deficiency. So these are very simple tests, and yeah, thank you. These are my acknowledgements.
Ma'am, I have a question for you. I have one question.
Yes.
I have divided it in two parts.
Yes.
What was the malignancy which were associated with these sort of
tumor-induced osteomalacia?
Malignant, because you said it's mostly benign. So any malignancies which were associated with
So these mesenchymal tumors are mostly benign, 90%, 10% have been found to be malignant. They are mesenchymal tumors.
Which were the commonest malignancies which were associated with?
They are all these. They are actually those mesenchymal tumors. They're exact. These are not actually gone through individual what they are.
And what was the what was the final outcome? What was the prognosis?
So prognosis is good. Most of the patients recover after removal of the tumor.
Any association with morbidity and mortality of the patient with this phosphate levels?
No, the FGF23 levels don't really correlate with that. Usually treatment, if you resect, it is curative. Once the FGF23...
So that level also comes back to
yes,
normal?
and usually there is a slow recovery of the BMD. There have been studies in which they've looked at the recovery of the BMD. There is a recovery of the osteomalacia and BMD after tumor resection. There have been difficulties in actually localizing these tumors. That seems to be the most predominant challenge because these tumors are not easily localized. Recently, because of the rotated scan, we are picking up more tumors. It's a form of PET CT in which you're looking at, which has enabled us, and that is supposed to be the most sensitive way of identifying these tumors. However, previously it used to be very difficult to localize. If you cannot localize, then usually the treatment is to give phosphate supplementation, give active vitamin D, 125 instead of giving usual vitamin D. And there has also been a phase 2 trial of a monoclonal antibody which inhibits FGF23, that's called burosumab or something. And that has undergone phase 2 trial, that inhibits FGF23 and also shown some positive results in this condition.
Thank you.
Good morning. To conclude this, based on the case Dr. Pinto has presented, this is a tumor-induced osteomalacia, which is oncogenic osteomalacia, and it's a rare paraneoplastic syndrome. To answer your question, sir, they are neuroendocrine tumors. They are paraneoplastic syndrome. They are usually mesenchymal benign tumors. So removal, actually localization, as she rightly pointed out, localization of the tumor and removal of the tumor cures the disease, both the malignancy as well as the osteomalacia. And these are secreting phosphaturic hormone, which is FGF23, which acts primarily at the proximal tubule, renal tubule, decreasing the phosphate reabsorption and 1-alpha hydroxylation of 25-hydroxy vitamin D, and thus producing hypophosphatemia and osteomalacia. And this is clinically characterized by bone pains, fractures and muscle weakness. The lesions are typically very small. They are benign mesenchymal tumors that may be found in the bone or soft tissue anywhere in the body. And in up to 60% of these tumors, the fibronectin-1 and the fibroblast growth factor receptor 1 fusion gene has been identified that may serve as a tumoral driver. The diagnosis is established by finding of a acquired chronic hypophosphatemia with concomitant elevated or inappropriately normal blood levels of FGF23 and decrease or inappropriately normal 125-hydroxy vitamin D. So the treatment is, it's a stepwise approach with a thorough medical history and physical examination followed by functional imaging, locating the tumor, that's the challenge, and complete removal is curative. And suspicious lesions should be confirmed by anatomical imaging, and as she rightly pointed out, the DOTA scan, and if needed, selective venous sampling with measurement of FGF23. If the tumor is not localized or surgical resection is not possible, then medical therapy with phosphate and active vitamin D is usually successful in healing the osteomalacia and reducing the symptoms. Careful monitoring is required to avoid complications. That's important to avoid secondary or tertiary hyperparathyroidism, hypercalciuria and nephrocalcinosis. And novel therapeutical approaches like image-guided tumor ablation and medical treatment with anti-FGF23 monoclonal antibody or anti-FGFR medications are available. So the diagnosis of tumor-induced osteomalacia should be considered in patients with bone pains, osteomalacia, which is low BMD, and hypophosphatemia, as well as a stepwise localization study of patients with suspected tumor-induced osteomalacia is needed. And in addition to that, when you are having a low BMD or osteoporosis, then one should keep in mind common as well as the drug-induced osteomalacia and medical conditions causing the osteoporosis and low BMD values. So with this, I would put a question that when we are doing a screening of osteoporosis, then we are usually in the scans on large scales. We are not carrying the big BMD machines, and we are usually carrying these ultrasound machines. So what is your take on this? What is your opinion? How reliable they are and how we should go about this?
Ma'am, it's a good question. And essentially, you see, I will be discussing the fracts. So at that point in time, there are a few controversies related. Not controversies really. The very fact that we will be discussing fracts means it's come of age, and it also means that there are a lot of newer modalities which have come up, including a peripheral quantitative CT, ultrasounds, where speed of sound and BUA are measured, but they are as of now not validated to be included in the fracts per se. So we will need a lot of data, and we should go ahead because it is non-invasive. There is hardly any side effect to it, and definitely ultrasound would be a good way to go forward. But we'll need a lot of data. All of this is a lot of data oriented, and we will have to generate that data for India in lots of, peripheral ultrasound is, futuristic, as the topic itself is futuristic. Even basic data as regards fractures and things like that are not available for the Indian scenario. So definitely it is going to come in a big way.
Sir, any opinion from your side?
So availability of ultrasound DEXA is available in India now, but the other peripheral ultrasound DEXA scanning and all these things are coming in on the big way to diagnose the early osteoporosis and all these things. So he will summarize all these things. In his topic, he will summarize. He will talk about the osteoporotic plaque score and all these things.
So would you like to take over?
I have one question.
Yes.
I have divided in two parts.
Yes.
What was the malignancy which were associated with these sort of
Tumor-induced osteomalacia?
malignant, because you said it's mostly benign. So any malignancies which were associated with
So these mesenchymal tumors are mostly benign, 90%, 10% have been found to be malignant. They are mesenchymal tumors.
which were the commonest malignancies which were associated with?
They are all these, they are actually those mesenchymal tumors. Their exact, these are not actually gone through individual what they are.
And what was the what was the final outcome? What was the prognosis?
So prognosis is good. Most of the patients recover after removal of the tumor.
Any association with morbidity and mortality of the patient with this phosphate levels?
No, the FGF23 levels don't really correlate with that. Usually treatment, if you resect, it is curative. Once the FGF23...
So that level also comes to back to
yes,
normal?
and usually there is a slow recovery of the BMD. There have been studies in which they've looked at the recovery of the BMD. There is a recovery of the osteomalacia and BMD after tumor resection. There have been difficulties in actually localizing these tumors. That seems to be the most predominant challenge because these tumors are not easily localized. Recently, because of the rotated scan, we are picking up more tumors. It's a form of PET CT in which you're looking at, which has enabled us, and that is supposed to be the most sensitive way of identifying these tumors. However, previously it used to be very difficult to localize. If you cannot localize, then usually the treatment is to give phosphate supplementation, give active vitamin D, 125 instead of giving usual vitamin D. And there has also been a phase 2 trial of a monoclonal antibody which inhibits FGF23, that's called burosumab or something. And that has undergone phase 2 trial, that inhibits FGF23 and also shown some positive results in this condition.
Thank you.
Good morning.
I was initially Benjita and I were discussing that we would be talking to each other. I'm very glad to see so many people have turned up. Now my next worry is I hope my talk is relevant enough for all of you. So I'll start with this slide. I always start my presentation with this, that the obvious facts are actually the most deceptive ones. And so is the case for osteoporosis and the treatment for osteoporosis. Maybe we've got it all on the wrong end altogether. And so why I say that is, my topic is to talk to you about the FRAX. FRAX is an assessment tool for assessing whether an individual requires treatment and is at such a risk due to the osteoporosis, whether an intervention is required or not. And of course, FRAX was developed in 2008 by the WHO, under the aegis of the WHO, and then it has been continued away from the aegis of the WHO. It was validated under the direction of Professor John Canis, with the support of many organizations like the National Osteoporosis Foundation, International Osteoporosis Foundation. Why I mention them is so that when you go back from here, all of you would be leading your practices in some hospital or the other. I do believe that FRAX is highly suited for a situation like India, and we should all adopt it. And maybe as rheumatologists, we should now start leading from the front in developing the FRAX more. So essentially what I'm saying is, since 2008, it is about 14 years that this tool, assessment tool, has been developed. And now it has come of age, because today we are discussing whether, is it valid or not. Of course it is valid, and it probably needs a lot more of work. Further things can be, but the most robust data is for FRAX. Of course, it brings us to the question, are there any other methods of assessing? I will be answering that as I move along. So this is the thing for all of us. Our population, even in India now, the average lifespan has increased. So we are going to look at points in time where all of us will be at risk for osteoporosis and osteoporotic fractures. I think Dr. Krishnamurthy mentioned, the fractures, osteopenic people also have fractures. Actually, the fact is the number of fragility fractures, because the definition is between a fragility fracture and a normal high intensity trauma fracture. The fragility fractures are maximum in the osteopenic patients, not in the osteoporotic. Now the reason for this is that the osteopenic absolute numbers are much higher than the osteoporotic fractures. And therefore, sir, your question regarding whom do we treat? Yes, that is what the FRAX is attempting to do. That is what various other tools which have been developed by other countries are also attempting to do. Because we can't be dependent only on the bone mineral densitometry, because that's only one part of it. Of course, I think I would exceed my limits if I go into the bone mineral densitometry per se. But suffice to say that, somewhere we use the terms bone mineral density and mass interchangeably. But this is not true, not entirely true, not entirely scientifically true, because bone mineral density is a separate issue, and the bone also has organic matrix which gives it strength. So it's not entirely true that bone mineral densitometry would be representative exactly of the osteoporosis and osteoporotic risk fracture which is there. Of course, this diagram would be this pictorial representation is self-explanatory. Low bone mass, micro-architectural disruption, and skeletal fragility. These are the hallmarks of osteoporosis. And like Benjita mentioned, osteomalacia is a different ballgame altogether out there. So now what we need, when we use tools, what are we trying to do? So this kind of would be a summary of what we've kind of discussed till now. We need to decide fracture risk assessment. Who are you going to assess? Are you going to assess everyone? Are you going to assess only the older people? Are you going to assess? So that's the first question we need to answer. Who to assess, how to assess, and when to assess. And it's all interrelated. Who out of these people, who all are we going to treat, and then how are we going to treat? The questions which were there. Should we use, say, denosumab, or should we use teriparatide, or should we just use bisphosphonate, or the SERMs, or the newer drugs? So the answer, in a way, is that most of these, like the FRAX also has been developed with keeping in mind the bisphosphonates, where we assume that it has about a 40% effectivity in treating osteoporosis. And the FRAX is a tool by which you may or may not use bone densitometry in it. And that is the answer to that question. In patients whom bone mineral densitometry is not possible because of either logistic issues, that they are located in a peripheral or rural setup, or very fact that a BMD machine cannot be transported everywhere. Dr. Preeti had asked, what about peripheral quantitative ultrasound measures, peripheral quantitative CTs, peripheral MRIs, and we even have the TBS, the trabecular bone score, which has come up now. But the answer to all of that is that the FRAX takes into account only the bone mineral densitometry. You can score a patient without the BMD and therefore decide the risk of that patient and decide to go on and treat that patient even without a BMD. That is to answer the question where I think one of you asked whether if a bed-bound patient is there, she's already had a fracture, an older individual, yes, we need to treat that patient. Of course, which choice of drug again would depend on the, I think we should use our own common sense and our feel about this patient. Because in FRAX, one of the controversies in such an older patient is, FRAX is a very refined tool, I would say, though I'm going to speak about the limitations. One of the limitations is that it can overestimate the fracture risk in such a patient scenario like what was mentioned, a very elderly individual who's bedbound, who's already suffered a fracture neck femur. Because FRAX takes into account the mortality also. So what I'm saying is this patient who is an elderly person who's suffered a fracture, the FRAX is going to overestimate the risk. But is it worthwhile treating the patient? At an emotional level, yes, definitely one should treat the patient. But at a cost effectivity issue, the mortality, the patient may not survive so long for even for most of us to assess the treatment at that point. So worldwide osteoporosis related fracture data, 1 in 3 women aged more than 50. 1 in 5 men aged more than 50. So of course, it means that this is the world data. So in India, probably we are still to generate that level of data. It's probably going on, and probably this is a right step. So I would commend Dr. Danda and his team for choosing this topic, because as rheumatologists, it's probably time now that we are sensitized and that we start recording data for our patients. We take an interest into vertebral fractures, because the very definition of a vertebral fracture at times is difficult. A lot of them may have a compression fracture which goes undetected. And like the first case that Benzita presented, a lot of patients who have back pain, but we never really focus on that. So it's a good time to start collating our data, generating, and maybe we can take a lead on it, have a special interest group or something like that, and move on from there. So obviously with this slide I'm trying to say that osteoporosis is a major issue. It is going to come up, even become a larger issue in times, and it will put a larger strain on the healthcare system. And if we can, as it says in this slide, the right lifestyle and medical treatment makes a huge difference. Essentially it is about an approach. So FRAX actually is a tool which is, I would say, uniquely suited for the Indian setting, because it is for the primary healthcare setup, and we can take it on from there. We are talking about rheumatology, which is a tertiary level issue, and we still probably have not, I don't know how many of you in your practice, at least I don't apply the FRAX to my patients. when I decide on a treatment protocol. I mean, it's a very subtle but simple thing. How many of you apply the FRAX score or tell your patients, empower your patients to go and use the FRAX tool? Because it is a simple web-based tool which is available out there. But how many of us have the time to do it? I don't think we do it. But I think if we apply that correct approach, we would be able to do it. It would benefit our patients and it would benefit the overall rheumatology fraternity because we would be generating much better data. So now what are the other instruments? Obviously, if FRAX isn't good enough, or we are talking that it should evolve more, that's how I put it. I wouldn't say it's not good enough. It is the best fracture risk analysis tool as of now. There are other tools which are there, like the CAROC in Canada, the Q-Fracture and the GAR1 in Australia. So these tools are present, but they are even lesser validated than the FRAX. One of the controversies with FRAX is that it is not validated in all the world populations. So how will that happen? It's probably now time for it to happen because we need to validate it for India especially because we are such an organized medical fraternity. And we have the potential to be able to generate it, but each of us will have to take those particular steps in our practices. Most of us are highly rushed and busy practices, difficult to apply, but of all the four screening instruments which I have put, FRAX is probably still by far the best in the leader, and it will evolve. So I don't think it would be possible for any other instrument to beat the FRAX at this point in time. So as I said, it was introduced in 2008, uses just clinical risk factors. It doesn't use too many clinical risk factors. For example, the difference between the CAROC and the FRAX uses just about 11 risk factors, whereas the CAROC uses 30 risk factors. But imagine we are not entering the FRAX for most of our patients. We don't assess the patient on the basis of the FRAX. That's what I said in the beginning. So when a patient comes to you where you suspect osteoporosis or you suspect that this patient, the best thing to do is step one, make the individual go through the FRAX. And if you find the FRAX, tending towards, obviously if the T-score is beyond minus 2.5, there's no further doubt. The doubt is for a score between minus 1 and minus 2.5. And in a younger individual who has a score between minus 1 and minus 2.5, that is the individual you need to apply the FRAX. And it's not a fixed, so I will use it interchangeably. I will say you should use the FRAX, and sometimes the BMD may come up, and that is the patient you will have to apply the FRAX for, whether you need to treat this patient or not. So the intervention threshold, which is what we were talking about, the intervention threshold is based upon economic and cost effectiveness analysis. And as I said, cost effective analysis is important, but not just the only this thing. So one of the controversies is also that the FRAX is valid only for untreated patients. And in treated patients, we do not do a follow-up with the FRAX. It has not been validated as of now. But most of the studies are tending to say that FRAX would be a valid tool even in those patients to assess their risk. You may have started a patient on treatment, patient may have fallen off the grid and not taken treatment, and do you reassess with FRAX? So as of now, we don't have the data, but the general recommendation would tend towards reassessing with FRAX. The FRAX, when it uses the BMD, takes into account only the femoral neck. It does not take into account the vertebral or any other site. Again, to answer Dr. Madam's question, where she had asked whether peripheral ultrasound would be adequate, because the peripheral ultrasound would be done at the calcaneum. It may not be adequate to extrapolate those findings as of now. But as we generate more and more data, I think it would become a valid tool, and we would also try to incorporate it into the FRAX. So this is a rough, this is an approach which has been suggested of how we should approach a patient. So if the patient has clinical risk factors, we approach the FRAX, we put him through the FRAX. And depending on the risk, whether it is high, intermediate or low, even for generating this data and to plot the point of this patient on the graph, we need to generate a lot more of data. That is very, very crucially important. As a country, we will have to move towards generating that data so that then we can assess the BMD and the probability and to consider the treatment. So first things first, we need to use the FRAX and we need to probably get all the other data. So I'll move a little bit more quickly because I think because it's already showing me an oops, your time is up. Anyways, this is the number needed to treat. Here you can see that somewhere around here is where it makes most sense to actually treat, and that is the recommendation by the National Osteoporosis Foundation also. And this is how the graph would look for a person based in the UK. We generate this graph, but we do not plot a point for the Indian patients, whereas in the UK there would be a plotting for the patient for the individual. Like for example, in your patient case, the plot, if it comes in the lower risk, you don't need to treat. If it comes in the in threshold to treat level, above the threshold to treat, you would treat. That's how it would work. And this is how the page looks at when you have to enter the FRAX score. Not very difficult. I think we could train the patients also and we could do this. It's not so difficult. So the advantages of the FRAX I've already gone through. I'll just kind of move through this a little bit fast. Limitations. The ethnicity and data has to be generated for each country. So it does not assess individuals less than 40 years or more than 90 years. And the FRAX algorithm uses only the T-scores for the femoral neck. Of course, there are a number of limitations for the FRAX. It can underestimate and it can overestimate things. And I'll just go to this slide directly because this is the National Osteoporosis Guidelines group. And you can see that they have addressed most of these issues, and there are adjustments that can be made towards this thing, and you can generate the score. So the FRAX itself will move towards this, and we will have a better FRAX which is there, rather than discarding the FRAX and trying to go on to some other tool. FRAX is the tool that I'd recommend very strongly. So this is how you should use the FRAX. Again, a comparison. And I will just, I'd like all of you to just kind of look at these examples. So here, it would probably answer some of your questions. A 50-year-old male smoker, so he's 50, he doesn't hit the 65 mark also, with chronic malabsorption, hypothyroidism, and a T-score of -1.8. So this is neither here nor there, -1.8. Would be denied therapeutic intervention if purely based on a FRAX score. So here's where the physician comes into play. So if the physician feels that he has risk factors which have not been accounted for in the FRAX, and he does believe that the score is under-representation, you have the freedom to choose. But the FRAX helps you guide this decision. Similarly, the next case and the last case, a 70-year-old woman, which was similar to the question which was asked. I think, the mortality increases as the person ages, and so maybe there is an overestimation of the risk, and maybe we should not be very aggressive in our management of those patients. This is just a method which we can apply towards our own practices, and which probably we should apply gradually to collection of data. So we'll have to have a more coherent approach towards screening of these patients, picking up these patients, and moving towards generating data. I'll leave you with this, that we become what we behold, we shape our tools, and thereafter our tools will shape us. Thank you.
Thank you, Dr. Doshi, for the excellent presentation. And because of time constraint, few questions, only one question.
Good morning, sir. The FRAX tool uses only BMD of the neck.
Correct.
Whereas for the perimenopausal woman or premature ovarian failure, it is the spine that is the most sensitive.
Yes.
So, is there any other tool or?
No, that's what can I go back to the presentation, please? You see, the National Osteoporosis Guidelines group
That's what I tried to highlight. I ran short of time, but they have already brought in an adjustment towards that that aspect of it, because the vertebra is mostly trabecular bone, and it is not even, the cortical element is very minimal. So obviously the FRAX is going to underestimate, because the T-score of the vertebra is not taken into account only. But the present day modifications are now bringing in the fact that you can take it into account and probably add a +10. There is a method to adding that. You will have to read that paper. You can add that element to it and it will give you a modified risk score. It has not come entirely into practice because these are all in the development phases, but it is coming. So you don't need to look anywhere else. FRAX is the best code. It has 14 years behind it, and all these modifications have already been thought of. And even the TBS, the trabecular bone score, I think most of you would be aware of it. It's a software which has come in, which can be incorporated into the modern machines. And it will give you the trabecular bone score also. The trabecular bone score would be much more relevant in cases of vertebral fractures. And that would address that issue in a menopausal woman where the FRAX may underestimate it. One is that you can modify it by adding a certain score, that you'll have to go through that process. And the other is that the TBS software itself would probably give you that answer.
Sir, many orthopedicians I could see after the osteoporotic fracture, they are anabolic
Yes. It's a very nice question actually. Yeah, most of us face this, but I think we need to educate our orthopedic colleagues that one of the indications to do a FRAX is when you decide to start a treatment for osteoporosis. So it's not entirely wrong that they have started. I'm not, so we don't have a very antagonistic path or a collision issue. We kind of say that why don't you do a FRAX? Because I think collaboration would be much better for all of us, for the most importantly for the patient, and then we can decide whether they, even before a knee replacement, they've already started the treatment for osteoporosis. Whether the bone score is, I mean, osteoporosis is different from osteoarthritis, where a knee replacement is.